Welcome to my podcast, The Laura Dowling Experience. Many of you will know me from my Instagram page, @FabulousPharmacist, where I love to shine a light on topics that people normally shy away from. Today I spoke with Professor Caitriona Ryan. Caitriona is a consultant dermatologist and female powerhouse. Today we answered lots of your dermatology questions, as well as discussing life, love, vaginas, and whether or not females really can have it all. To support the Laura Dowling Experience, please check out our sponsors in the podcast notes below. Enjoy the show. So Caitriona, clearly there is women out there that can have it all.
No, I definitely don't have it all at all, Laura. But I do think, I think we can have so much nowadays. I think things have changed so much.
Yeah.
I often say I would never swap to be a man. I love being a woman.
Yeah, I'm the same.
I think we hear so much about how women have it so tough and blah, blah, blah and whatever else. And yes, we do, in certain ways, especially if you're trying to, actually, even if, you're at home all the time, that I think almost is tougher than working as well, in some ways. But I actually think we're so lucky to be able to do it all or as much of it as we want.
Yeah.
So yeah, I'd never swap to be a man.
No, I wouldn't either. I love being a woman. However, this summer has been the first summer that I worked from home as such, because obviously I had a little bit of a career change. And I've been finding it tough now with the kids at home and trying to work and all that. So I'm dying for them to go back to school.
Oh, listen, I don't think until I have my kids of my own, I don't think I had, I have so much admiration now for women at home. I couldn't do it full time. It is so hard. There's so much patience involved, and there's times that are quite boring and whatnot too. A bank holiday weekend is long enough for me. I am running into work at the end of a bank holiday weekend. So I don't think I ever gave kudos to these women who do it all at home. It is. That's really, really challenging.
No, it's bloody tough, isn't it?
Yeah, it really, really is. So, yeah, no, I totally agree with that.
Your babies are small though. How old are they?
My babies are 22 months and just gone 3. And then I have 5 stepkids as well. But they're not babies. They're
how old are they?
11, 13, 14, 23 and 25.
So you took on a whole new family?
A whole 3 families.
Oh.
3 families, but it works really, really well. Like my stepkids are all amazing, and Tommy and Charlie adore them. They talk about their brothers and sisters. We see we have George riding Connie every second weekend, and that's all they talk about between visits.
Isn't that lovely?
It is lovely. It's lovely, lovely, lovely. It sounds crazy, but it's not at all actually. And they're such a huge.
So is your house like mad? So you've a busy work practice, obviously. We'll get into that. And then at the weekends, you've like loads of kids hanging around all the time.
Madness, like absolute madness, and I love it that way.
Okay.
I came from a family of family of 6, 4 kids. John had 6 kids in his family. And yeah, I love that. I love the busyness and whatnot too.
Okay.
Yeah, the more the merrier. We often have visitors as well. So this weekend we have people staying from Texas.
And that's where you studied, isn't it? Or that's where you...
I spent 7 years there. So I repeated my dermatology training there, and then I was an associate professor over there for the rest of the 7 years that I was there for. So really special time in my life. 7 of the best, years of my life.
My mum worked out in Texas as a midwife when she was younger, and she loved it out there too.
Like, it is so fab. Actually, I think, Laura, you would suit Texas so well. I can actually see you there, and Texans would love you. They are the most fun-loving, warm people you could ever meet. I still get messages from my patients back there.
Why
really,
did you
really
leave?
great. Because I love Dublin, I love Ireland. It was like I was living an extended holiday. It wasn't real life. It was so much fun. The people were great and whatnot. And then John, I met John when I was over there. So we did long distance for over 4 years. And I was ready to come home. Like I was really ready to come home when I did. And I love being home.
Yeah.
I think it's funny. I have lots of patients who've done similar things, or maybe been in, the Middle East for a long time, or, in the States or wherever, or the UK. And it's very rare people come home to Ireland and hate it. Like, I think I appreciate even more, what we have here. I think Dublin is a great city to live in.
Yeah. And when you say you repeated your dermatology training over there, why did you repeat it? Could you not just take over where you left off?
No, in the States, they don't recognise dermatology training from anywhere else, actually, apart from the States. So I'd already I had done 2 years. I was a specialist registrar in dermatology when I left, and actually I was only meant to go for 1 year to do translational research in the lab. All very boring, but scientific stuff. Trying to translate. What I was trying to do is figure out ways we could test people's blood to work out exactly what treatment they should be getting for their psoriasis. Psoriasis is one of my big research interests. But the plan was to go there for a year and use that data to do a PhD, and the plan had been to go to London and do the PhD there. And I went over, and I loved it so much more than I even thought I would. And actually, when I arrived over, my boss there, or my mentor, one of the great men in my life, had
Did you have many great men in your life?
I have. I've been really lucky with both my mentors. I really have.
Lovely.
And he's like a second dad to me. I really miss him. That's one of the big things I miss about Texas. But he had said, would you do the residency here? And I was like, absolutely no way. I'm going back home, and he took me closer to home. And as the year went on, I changed my mind. I'd been to London. The PhD wasn't the right fit for me. I was actually devastated because I'm a big planner. I plan my life. I can see, I try to visualize whatever else. And I saw myself living in London, doing a PhD in one of the top institutes in Europe, immunology wise for psoriasis, and living the dream in London. And then, I visited, and I won't even go into the details, but it wasn't going to be the right PhD at all. And I was a bit devastated because, and I arrived back, and I was like, I don't know what to do. There was opportunities in other places and whatnot. And then I said, what? I love it here so much. I'm getting brilliant research done in the lab. So I went back to him and I said, is the offer still open? And he was like, oh my God, Caitriona, yeah, whatever. So I had to start from scratch again, though. I even had to be a medical intern again. So I had been, an intern, which is your first year of being a junior doctor, 7 years previously. And I was running around the hospital on call again. I had to do that for a year. And actually, I really enjoyed that in the end because I was out of hospital medicine at that point. So it was great to be able to do it knowing that it was just for a year again.
Okay.
And then I did my dermatology training, and I was doing a lot of research on the side as well. And then went into practicing over there. So it wasn't what I had planned.
Yeah.
But it worked out so much better in every way.
And did that bit of research that you did, trying to pinpoint why someone might have psoriasis, or trying to pinpoint, the treatment plan for them, did that work out? Can you do that? No. Because I was like, that sounds really interesting.
That for me, you've no idea. And I could never be a scientist because I was so excited. I thought I would have the breakthrough, personalized medicine. That's what it's all about.
Yeah.
And we did, I collected blood from so many patients. I was up till 1, 2 a.m. in the lab, spinning cells, doing all sorts of things. And it turned out that the signature in blood is very, very weak in psoriasis. What I should have been doing is taking biopsies of their skin, and that might have, anyway, a year later, we published in different things, and whatever but it wasn't good enough data to bring it anywhere else.
Okay.
But I suppose what it did immerse me in was the research world, and everything that goes on. I was over in a lab. It was one of the top immunology labs actually in Texas. A lot of vaccines being made there and whatnot. So I got to see and really understand what goes on behind all of, the scientific developments and whatnot, especially when it comes to drug development and everything that's with that. But what I went on to do from that was run clinical trials. So run the drug trials for psoriasis. So the type of drugs that, have come to market just in the last, say, year or two in Ireland, I was using, 12 years ago in clinical trials over there. And I loved that, patients getting the top drugs much earlier on. There was always a chance you could get placebo, but that was something I loved.
Yeah.
Drug development, bringing the newer, most targeted treatments. So, it was great.
Do you think that we're very behind here with that? The whole, America seems to be steamrolling ahead a lot all the time. It seems to be that Ireland are very much behind in terms of, introducing, say, high-tech drugs onto the schemes and stuff like that.
So we weren't until relatively recently, and it's to do with pharmacoeconomics. It's Ireland deciding to reimburse drugs that have been approved by the European Medicines Agency. So, the EMA and the FDA typically approved drugs around the same time, give or take a few months. So something can be authorised for use in Ireland, but it's that our reimbursement scheme, so to get it on the drug payment scheme, which you're very familiar with from pharmacies and whatnot, can take so much longer than other European countries. Embarrassingly so. It was a particular drug for eczema that that was life changing for so many patients, and we were the last in Europe, bar Greece, to allow reimbursement for this. And it was especially when you see patients with horrendous eczema who haven't slept in years, because of the horrendous itch, and it impacts every aspect of their life. They've chosen different careers because of it. They aren't in relationships. All of the impact it can have, and you have a drug there that could change their lives completely. That sort of lag is something that needs to be addressed.
Yeah,
and I know there. One of the issues is we only have so much money as a country, and prioritizing what should come first. But when there's no drug in an arena, that sort of thing needs to be looked at. And I don't think that we have a transparent process for what happens to get these drugs.
No, not at all.
And that's what we need to examine. And I think it has been examined, but the report's not published yet. What our process is, so that we can work out why we're being failed with all of that sort of thing.
Yeah. So psoriasis is the topic that you're most interested in, is it? Or do you just love all kinds of...
I love everything. I love everything. I do medical and cosmetic dermatology. So cosmetic dermatology is the fun bit of my practice. And rewarding in its own way. But the medical dermatology, especially when it comes to inflammatory conditions, are what I like as a group.
Mm-hmm.
So somebody comes covered in psoriasis, or somebody comes with terrible acne, or someone comes with rosacea, which, they're, afraid to, it's so bad that they can't leave their house without makeup or whatnot. I love treating those conditions. And that's one of the lovely things about dermatology. I definitely think I have the best job in medicine. It's very rare you can't fix somebody, or you may not cure them, but keep whatever it is under control.
Yeah,
so rare for us. We're really, really lucky. And whether it's an inflammatory condition that you're treating, or a skin cancer that you cut out, or fixing someone's wrinkles, there's very few patients who you haven't improved, and that is it's phenomenal. I have friends who are in other spheres of medicine, like, nephrology, which is kidneys, or other things like that. And you can't really make people all that much better. You're just maintaining them. I have so much gratification in my job. I love my job.
Yeah.
And I have never met a dermatologist who doesn't, so. I'm really, really lucky that way. So it definitely would be for me. I get my biggest kick from the inflammatory conditions, and that's psoriasis, eczema, acne, rosacea, whatnot. And I suppose because I also love the science behind them, and I spent a lot of time in the lab looking at those sort of inflammatory pathways, whatnot. So the nerd in me loves it too.
Yeah.
And then having patients, and often, Laura, they're patients who are, in their 20s, 30s, or even in their teens, really formative time for them and who they're going to be. And to see the transformation in somebody who comes in with 80% of their body covered in psoriasis, and you start them on a medication and they arrive back in, 6 weeks later, and they have no psoriasis anymore, something that they've been dealing with for 5 or 6 years, whatnot. It actually, I get quite emotional when they come in. And often they will too, saying that, I haven't worn a t-shirt in the last whatever else, or, I haven't been able to get into a relationship. I'm so ashamed of my body. I couldn't take my clothes off in front of anyone. I've seen it over and over and over. And it's so gratifying, to be able to do that. And obviously it's a drug that's doing it, not me. But
there's a little bit of you though, a little bit of your magic.
But yeah, so, it's great. And I suppose that's why I love psoriasis, the advances that have been made in drug treatment in the last 20 years in psoriasis are phenomenal. Actually, it has become harder for me to treat someone who only has a little bit of psoriasis, because you're still stuck with the same topicals we had 40 years ago.
Yeah.
If they come in with a little bit that's really annoying them, compared to if someone comes in with, full body coverage of psoriasis, or even 10% of their body coverage, I can pretty much always clear them. You know,
It's
and
great.
you know all
but
of
sure,
the
even
drugs,
since I've been out
biologics.
in 20, you know, I've been a pharmacist for 20 years, and the amount of high techs that were prescribed back then were minimal. Now you're giving out high techs nearly every day, and it's for conditions like psoriasis. And in terms of psoriasis, is there any dietary factor to the maintenance or help?
Yeah, we
that?
get asked this all the time, and I was part of a consensus group that, you know, we examined all of the evidence. There are so many studies looking at this, you know, and you know, dietary components, and patients always want to hear, or they always want you to tell them that it's something they're eating and this is what's giving them the psoriasis. It isn't, and nothing in specifically worsens psoriasis apart from that you know take it, apart from alcohol that has been, you know,
does
definitely
it?
shown. Yeah, no, it doesn't mean you can't drink.
God, I'd be
excessive
devastated.
but people certainly flare when they have you know, when especially and they'll notice it themselves. They'll have a heavy weekend and the psoriasis is starting to flare a bit the next week. Also, psoriasis patients drink more, and part of that could be the, you know, the psychological, you know, effects of psoriasis drive them to drink more as well. If somebody is, say, a celiac, gluten may exacerbate it because, you know, the inflammation in their body or whatnot. But really, what our research showed was that it's a healthy diet you need in psoriasis.
Okay.
You know, because another issue.
So the whole dairy thing is BS.
No, everyone comes in and everyone wants to think everything is dairy, dairy or gluten. Like, and as I say, if you're celiac, different, but it isn't gluten for everyone else. And one of the biggest issues actually with psoriasis as well, we know that being overweight worsens it. And that's why I say a healthy diet.
And is that something to do with the inflammatory process in the body then as well, maybe?
Yeah, we think so. Like, it's chicken and egg. Is it because you have psoriasis that you don't want to go to the gym, or you're not as invested in yourself and, you know, whatnot too? We know that fat cells, so adipocytes, so they're your cells that make fat, release TNF alpha. And that's something that's important in the inflammatory pathway of psoriasis. So being overweight exacerbates your disease. So a healthy diet, a Mediterranean diet is usually what I would advocate, is the best thing, keeping things healthy and balanced, but no fad diets, no cutting out dairy or whatever else.
Okay.
You know, and it's, I suppose, one of the things I say to patients as well, they often think that they've caused their disease, you know, that it's something that they're doing. It isn't at all.
Okay.
You know, it's an interplay between genetics and their environment and whatnot. Stress will worsen it for sure.
Yeah.
That's very hard to control. It's very easy to tell someone, I think your stress is worth it, you know.
Yeah, I
make
know.
it worse. Well,
yeah.
You know,
And then it's like a vicious cycle as well then too.
then the psoriasis makes them stressed, and absolutely, you know, and we see high levels of depression and anxiety with psoriasis.
Yeah,
That's
of course.
been shown. Yeah.
So another aspect to your business is the cosmetic part, which is the part that I met you over.
Yes. Well, no, you
I have
maybe
a
over
face
lots of
full
stuff.
of Botox.
Yeah.
But how did you get into that? Because you did come back from, like, it's all the rage now. And I suppose the question about it is, you know, at what point are we encouraging women to change their faces too much? Or, you know, has it gone too much the other way, where there's young girls that are looking at themselves constantly in the mirror thinking that they could improve their, you know, they could plump up their lips, or they could give themselves Botox. You know, when is too much too much? I know there's loads of questions in there, so maybe just to get your thoughts on that, because
so when is too much, you know, at any point, I suppose the thing for me, you know, and the way I was in the States, you're trained very comprehensively in cosmetic dermatology. It's a big part of your training scheme, and the aesthetics of beauty. And I think certainly, you know, there's a huge difference. When I left compared to when I returned 7 years later, you're right, it was a wham bam boom. You know, Botox is just, you know, a normal word in our vocabulary now.
It's like going for bikini wax, and then everyone's comparing notes. So who do you go to?
Absolutely, and especially in the younger generations. When is too much? As soon as somebody stops looking like themselves, though, I think is the easy answer to that. You know, what we're trying, what I am never trying to do is change the way somebody looks. You're trying to bring them back to themselves, you know, and enhance their beauty. But I will say that bad cosmetic work or too much is when you can tell that they've had something done. It's as simple as that. The lip thing is very different. The lip thing is a trend. people, it's like carrying a, Michael Kors bag or whatever that, that age group are doing as well. That is very much a trend, and a trend, I expect to disappear in the next sort of 2 to 3 years. I think it already is. And there will always be these sort of, I won't say beauty trends because it's more than that, but it's like, there was a time when lots of people were getting their boobs done. And then, smaller boobs became more of a thing. And, all of that, especially in that really sort of, say vulnerable, but also curious, or there's an age group that you will sort of tinker with things a little bit more. You'll experiment with things more, and it's that age group. The funny thing is, I've never ever had anyone come into my clinic asking me for bigger lips.
Have you not?
No, never. Sorry, people will come in and say my lips are starting to look really thin and shrunken. Yes, I certainly inject lots of lips, but we're trying to restore back to what they had. Your lips do start to atrophy or shrivel. You'll see the little lines in them, from even your mid-20s on, and restoring to what they used to look like. Absolutely, but I've never had anyone come into my clinic
looking for a trout pout or
no, and I think it's because that isn't our demographic, our age demographic.
Yeah,
and yes, I think social media has so much to answer for. Like it is the it's an impressionable audience, and as you say, these things get normalized, and they've done really good research showing that if you say, if I gave you 20 pictures of lips, and you have to choose what the perfect lip is, and say you'll be middle of the ground or whatever else of all the lips, and then if you're sat in front of lots of images, like we scroll on Instagram over and over and over, and given the same ones, and a day later, you'll go much further to the right, to the bigger lip. And that's what happens to us. And that's the power of social media and whatnot too, on these girls who then feel inadequate with their normal lips.
They did the same kind of a study. It wasn't a study, it was more of like a gimmicky thing, but where they showed teenage boys pictures, or they were actually real women lined up, I think, of women just standing naked in front of them. So there were all ranges, all like, hair, no hair, boobs, fake boobs, and all. So they said to these teenage boys, pick the woman with the most natural body, and they all went for the big pneumatic boobs and the no hair, because that's what they're seeing on porn, and that's what they think is a normal body.
Yeah.
She's like, get a fright when someone takes their clothes off in front of them. But that's terrible, isn't it? Because
it's also terrible for the poor women that those guys then meet, because nobody ever measures up.
Yeah.
It is, and I think, and how do we control it? This is the issue with the internet and social media, or how do we normalize, or show what normal is, and embrace normal. It's I think of this for Tommy and Charlie growing up, more Charlie, I found being a teenager hard enough.
Yeah.
Particularly that sort of, 14-year-old age.
Gangly stage, yeah.
Yeah, I was so awkward. But like, if I had all of that on, and when I see the girls that come into my clinic, I see an awful lot of teenagers, and they are so adult, and they have perfect makeup, and they, oh my gosh,
I know.
There's such pressure on our.
When I think of the way I used to go around with like this gold sparkling eyeshadow, thinking I
don't think I even knew what my makeup was until I was about 20. I was so like gormless,
Yeah.
But like happily so.
Yeah.
And there's no escaping it now for them. So yeah, no, I think it's awful. I think I've totally sidetracked though. When is cosmetic? Is the cosmetics too much? I'll tell you, Laura, what I do have happening. And I suppose it's about the way we view ourselves. You see yourself in 2D. Everyone else sees you in 3D. So often, and it's actually, there's two I'm thinking of, and they're two of my favorite patients, and both, real high achieving women. They'll turn up my list and they'll come in and say, I'm like, why are you here? And because they have me there too long ago, whatever else. I just want another little bit of filler, just for down here or whatever else. And I'll say, no, you are going to turn into a pillow face. You look perfect right now. Every little line in hollow is noticed, and they want to fill every line. They're not looking at the overall global, view of themselves. So that happens a lot, and I think this is where things go wrong, because other injectors will just do what somebody asks. And I will tell you, anytime I've said no, whoever it is always completely grateful and thankful for it. But there often isn't someone to stop them from continuing, on and on and on. And I think that's where all of these overdone people that you see, it's people chasing every line and wrinkle and hollow.
But I think I see, is there a case of, so people can look really good for about 10 years getting the stuff done. So, I've seen it where women just look brilliant. But then there seems to be a point in time where they I might see them, they might come into the pharmacy, I don't know, might see them and it just, they've gone over the edge. Over. It's almost like they've tipped over the edge. And is that a case of they actually are much older now, or 10 years older now, and they just can't, their face can't take all that anymore, and they need to stop doing it or do it less or do something else, actually go under the knife? Like, when does it get to the point where, like, how can someone continue to look great throughout? Like, I'm thinking of Jennifer Aniston.
Oh my God.
Because she was amazing. She was amazing up until I saw her like in the last 2 years.
Yeah.
She's just gone that pillow face that you've said.
And Nicole Kidman as well.
And the eyes are kind of a little bit more sunken. So it's like, how do you stop that process? Is there, And
I think what's happened there, I have no idea what she gets, but Jennifer Aniston was sort of my poster child for aging gracefully, because she always looked so well, but never overdone or overfilled. And I was sure she was using Sculptra. Sculptra is what I put into my own face, the one that stimulates your own collagen, so it never bulks you, but it tightens your skin at the same time. And there's a certain point that I move my patients, that have been getting hyaluronic acid fillers over to that for that very, very reason. And it's all I use on men too. And I was sure she was getting it the whole time. I think she must have swapped, changed dermatologist or something, because what she has in now is definitely hyaluronic acid filler, and it is far too much, and she is a pillow face.
Yeah.
And there's definitely also, Laura, a time for surgery. And there's, again, there's patients who will come into me and, I tell them, you could spend all the money in the world on our machines downstairs, especially, tightening machines and whatnot, and you will be wasting it. You need to go for a facelift or a neck lift. Like, there is definitely a time when surgery is needed. But I think knowing that point, and you've gotten it totally right, somebody is good, and then gone. And it's
like a point in time, and it's like, Jesus, that's they've just gone over the edge, or something's happened. And how do you prevent that if
it's going to the right person who's going to say no? Is going to say, no, we're going to change tax now.
Okay.
And for me, there's a point with most of my patients that I say to them, it's time for moving over to Sculptra. It takes 6 months to take effect, whatever else. But it is much better future-proofing. It's not just filling things, out or providing scaffolding. It's inducing your own collagen. So that's where I move over.
Okay. And then if you stop getting it done, so just because, people will often ask, if I'm getting Botox or fillers done, and then I just stop, does your face fall down? Does it fall back? Or
No. So you lose that volume within your face, but you're still in a better position than you would have been if you hadn't had it.
Okay, so you won't like revert back and just wake up one day and just look,
no,
like your face fell.
No, and especially when it comes to, I think I hear that so much more about Botox. They say, I know I look good when I have it, but then does my skin get much more saggy and everything else? Because I stop it, and the answer is no. They've done a really nice twin study actually showing one twin who never got Botox and the other twin who had it for 10 years. And the preventative effect of that, of not allowing that strong glabellar complex, the muscles between your eyes that make you frown, stopping that from pulling down your eyebrows makes a huge improvement over time. So even if you've had those years of preventative action there, so that you're definitely in a better place than if you hadn't done it.
Okay, and what about the worry about a muscle atrophy?
That's what we're trying to do. We're trying to selectively atrophy this muscle to get rid of the ridge here, because it's that muscle mass that's pulling down. And when it comes to your forehead, there should never be muscle atrophy. What you're trying to do is, relax those muscles. It's so important that you don't. You're very subtly relaxing them, but you should always be able to make your movements. If you can't do a surprise face with Botox, it's bad Botox.
Okay.
There you go. You always need to be able to animate, though. Really, really important.
Yeah.
So there should never be atrophy of those muscles. And here I'm sort of trying to achieve that.
Yeah.
And people look so much better if they don't have this heavy, angry ridge over their eyebrows. so many people, that's what, what they'll say. They'll say, I look angry. I'm not an angry person. I'm happy
Bitchy
on the
resting
inside.
face, isn't that it?
Yeah.
Okay.
And that happens to so many people as they get older. And that, it's incredible how looking happier makes you more attractive. You want to talk to this person and not to, this person.
They say you perform better in job interviews and everything if you're, you don't have that kind of bitchy resting face. But
absolutely, because people want to, they want to interact with you. You're more inviting as a person with a smile on your face, and you're more attractive for sure. There's no question.
Yeah. So when you came back from America and you set up the institute, it was like you were one of the first, weren't you, to get all those machines in that? How was that received from other, I suppose, dermatologists in Ireland in general? Were you well received? Was it a bit kind
absolutely.
of like...
We have a lovely, there aren't many dermatologists, you probably know.
I'm going to get onto the waiting list problem in a minute. I had to ask that.
But I suppose you don't hear the bad stuff. But everyone was very supportive. There's myself and Nikki opened it together, but we have another 5 dermatologists who practice out of it, out of the institute. So they all have different sessions that they come to the institute to see their patients for. So we already have 7 of the dermatologists working in the institute, and nothing but I feel like nice support. Colleagues email to say well done. We really needed this, and I think what people had really wanted for a long time is a bit more governance of the cosmetic dermatology space, so that we were had a place that everybody knew was being run by dermatologists, and the oversight that involves as well. So it was really well received.
That's
Laura.
good.
Yeah, we were very lucky. And support from every angle, really.
Yeah. And what are your thoughts then on people injecting fillers in that aren't doctors? Have you seen have people had come to you to get recorrective?
Yes. I've had lots of that, having to dissolve out fillers. I don't think it necessarily needs to be a doctor or a nurse or a dentist, but somebody who has medical and clinical knowledge, and somebody who can write a prescription. I think that's really, really important as well. My what I worry about is non-medical people. So beauty therapists or whatnot injecting fillers, because it's not the bad result. Everybody knows where they were going to get it done. Somebody could have sort of stupid looking fillers. It's not that worries me. It's the potential of blocking an artery, causing death of tissue. I've seen some horrible scarring from people injecting into arteries, and actually in some very rare cases, luckily it's never happened in Ireland, blindness from injecting filler into places. Like, it's so important that the anatomy of the face, and the anatomy in everyone's face can be different, that the anatomy is known really well, that the injection technique is safe. But most importantly, even the best injector, there will be complications, because everyone's anatomy is different. The artery that usually tracks one way may track another way. And the most important thing is that somebody can deal with the complication. And in the case of fillers, it's injecting the antidote for hyaluronic acid, which is hyaluronidase, immediately to flood the area and dissolve the filler so that it stops blocking that artery. And only doctors, dentists, or supervised nurses are allowed to have that. It's a prescription only, it's a prescription only medicine. So, and that's what bothers me about fillers. Anyone could buy them, but I think nobody should be allowed to have them if they cannot, if they're not medical, to be able to inject the hyaluronidase for if something goes wrong, because things will go wrong.
And why isn't it a case then that why don't they just move hyaluronic acid onto prescription only then? In that case,
I don't know, because the way it's been registered and have been registered for years and years and years is as a medical device, as opposed to a prescription. So Botox is, doctors only, doctors and dentists only. But Botox is dangerous. Yes, you could look stupid for 3 months if you get it poorly injected, but there's no danger of Botox. Whereas fillers can actually cause, horrendous, scarring, really bad infections. That's the other thing, if somebody gets an infection, infections can happen too. Luckily, I've never had one in any patient, but they need antibiotics.
Yeah.
First of all, they need to be assessed to see if it's an infection or not. And again, a non-clinical person can't do that. They can't tell the difference between a hypersensitivity reaction, which is an allergic reaction, which needs to be dealt with completely different, compared to an infection. And then a blockage is even more serious. So really, really important. And people have been shouting about this for the last couple of years, but nothing has been done to change it. And I think, fillers should not be allowed to be used apart from people who are licensed to have hyaluronidase and to inject it.
I remember one time I got my Botox done. This is just an aside, because it's just when you were saying about how things can go wrong. And I went swimming I went swimming within a couple of hours, like an Aegis, right? And my goggles are real tight, and I was like, I came out of the pool, and I thought I was going to be that forever, and I thank God it actually calmed down. But literally for a few hours, my eyes were like, it was
oh God.
But only me, because I'm always rushing. It's always like if I'm either in work or rushing to go to the gym or rushing to get back to the kids. Like I'm always mental busy, and I just was like, oh, I'll just rush it, run in and get my
swim in.
I get my swim in, and then not thinking. Whereas I know that you should relax. I know you can go to the gym, but you probably should relax, just like take it easy that day. But I never take it easy because, like you, it's just busy, that kind of way.
That's totally like me in my life. And actually with Botox, it says on all the post-care, don't do any strenuous exercise for 24 hours, but it's irreversibly bound after 90 minutes. So I tell people they do whatever they want after 90 minutes.
Yeah.
Yeah. And it really doesn't travel under the skin. It's been absorbed by the muscle at that stage. But yeah, that could happen. I would have paid to see that now. For 3 months. It only lasted the kind of the evening/day, but I honestly thought it was going to be like that. I scared myself. I was like, why am I always rushing everywhere? But it's the nature of the game with me. And you haven't stopped rushing anywhere.
No, I know, but I think that's just the way it is. But in terms of acne, and I've had the Roaccutane, and it is just phenomenal what the Roaccutane can do for someone when you're in that zone where it was me the hormonal, the cystic acne. And I think there's a lot of kind of miseducation or misunderstanding around Roaccutane and the whole depression element of that too. And I know certainly like years ago when I should have taken it, like I probably should have taken it about 20 years ago and just cleared it up once and for all. But I didn't. And I suppose it wasn't as prescribed as regularly then for hormonal acne. You really had to be in a jock to get it 20 years ago. But it's all changed now. So can you just allude to a little bit about
Yeah, absolutely. And I took it myself when I was 20. And I'm so glad I did. Back then it was life-changing for me at the time. And luckily I wasn't left with much scarring. I think you described so many people though, Laura, because if you have horrible nodular cystic acne, they will, most of those patients will manage to get Roaccutane. It's the people who have this grumbling cystic hormonal acne that fall to the wayside, and they're given antibiotic after antibiotic after antibiotic, or often kept on birth control pills for years and years and years, but it still creeps through. And my issue with that is even if you have one cyst that leaves a scar a month, over lots and lots of months, you're going to have lots and lots of little scars, particularly on the lower face. So, there's lots of people who are suitable for it. It is a drug that has to be taken seriously. So, and Roaccutane can cause depression. That's definitely true. It's very rare. I've only ever seen it 4 times in my career, and I've treated thousands in the States and in Ireland. And actually, I would also say that I have lots of kids come to me who have a history of depression or anxiety, and I'll send them to I always will send them to a psychiatrist. Most of the time I'll send them to a psychiatrist if they've needed medication or whatever in the past. And the psychiatrist, for
an assessment before you put them on Roaccutane.
Yeah. And that can be a rate limiting step because it takes a long time to get into a psychiatrist right now too. But the psychiatrists have always said yes, bar 2 cases, and that was more to do with other issues outside of the acne depression. They will always say yes because they see the overwhelming benefit it has to somebody with severe acne on the way they interact with the world, their confidence and everything that feeds back. It's not it's not it's not a vanity thing. It's, you know, you the way you look, the way you see yourself truly does affect the way you hold yourself, your confidence, the way you interact with, you know, your peers, with your family, with your friends, with your partner, whatever else too, with every aspect of a skin disease. So the interesting thing is that the studies, you know, the big good studies, the meta-analysis and the database studies and whatnot, none of them show an increase in depression. They actually, you know, some show an improvement in depressive symptoms, because when you put everyone together, the overwhelming thing is that people feel happier when their skin looks better.
Yeah.
But that hides the very rare cases that people, you know, of the people who did develop a bad mood. The issue, I suppose, the thing is, if somebody develops a low mood, the drug has a half-life of 22 hours. It's out of your system very quickly. So I just have everyone on high alert for that, and their parents. You know, they're allowed to have their normal 14, 15-year-old moods. But anything that's not normal, and then we would stop the drug if there was an issue. And the other big thing, obviously, is getting pregnant. Like, nobody can get pregnant on Roaccutane, and for a month after stopping the drug, because it's what it really is high dose vitamin A, an analog of vitamin A, which is toxic to the fetus. And I have had someone get pregnant before. She was 35, married with a child. This was over in Texas, and that was really, really tough for me. I still think about that girl. So it has to be taken seriously. It is a serious drug, and it's an amazing drug. You know, it's been life-changing for so many people. All the cards in my office, all the little thank you cards, I would say 95% of them are from patients who have done Roaccutane, but it is a drug that needs to be taken seriously. Yeah. And it's a cumbersome drug. You'll remember yourself.
Oh my goodness, the joint pain. And I woke up, the lips thing, was really cumbersome. Like, I used to put not Vaseline, I was using Aquaphor. I found the Eucerin one really good. Aquaphor, brilliant, so good. Because I've tried, you know, I tried all of them, and it was the joint pain, because I remember waking up like a couple of mornings going, "Geez, I must be getting old. My joints are killing me," and I couldn't run, and I stopped doing yoga even for the time that I was on Roaccutane. So because I just couldn't bend. I wasn't as flexible at all. So it does have those. And effects.
The older you are, not that you're old, you're younger than me, but the older you are, the more achiness people have. That's for sure. And I say that to, you know, my patients who are in their 40s, 50s, you know, you will get achy on this. It doesn't damage your joints, but it could, you know, you'll feel it after you've worked out, or, you know, whatever else.
But you revert back very quickly.
Yeah, the drug only has a half-life of 22 hours, so it's fully out of your system in about 5 days usually. Yeah. So everything goes back to normal then. Your skin takes about 4 weeks to get back to normal because of the skin cycle, you know. But yeah, no, it's great. But yeah, there is a lot of you know, negativity towards Roaccutane on the internet for sure.
Yeah, but it's like the negativity towards breast cancer on HRT. It's almost like this historical kind of negativity that's kind of been brought through, even though there's been loads of trials and studies done recently, you know, like in the past few years, that does go to show you that, you know, the kind of all that kind of hysteria around it
Absolutely.
is not.
And I suppose the other thing is, you know, the very time that people get Roaccutane, well, the vast majority of people get Roaccutane, is also a time that you see more anxiety and depression in that age group. And it can be hard to work, you know, and I think especially if something goes wrong in somebody's life, it is, you know, people will look for what did they do differently. And it must have been this or it must have been that. And we see that a lot, I think, as well. So.
And the pregnancy prevention program doesn't affect boys, sure it doesn't, or men. No, they can still have unprotected sex with their partner,
and they don't. They only have to be seen every 2 months. We have to see all women every month.
It is a drag, isn't it?
It's a drag.
And it's expensive for them too.
It is, because they have patient visits. They have the Roaccutane, and now Roaccutane is so cheap here compared to the States. Though in the States, if you didn't have health insurance, it could be up to €900 a month. It's ridiculous.
How does that whole medicine thing work over there?
Crazy.
So it's all insurance run, yeah?
Yeah, but lots of people don't have insurance, or they're changing job and they have a gap in insurance, and it's such a racket, Laura, it kills me. You know, everybody's taking a piece of the pie, you know, on the way down, and there's, you know, schemes between insurance companies and pharmacies and whatnot. But like, say, doxycycline, which I use a lot of, you know, it's an antibiotic for rosacea, acne. How much is that now in a pharmacy?
Like
for a month.
It could be €10 maybe, something
€600 for a month in the States. It's sometimes like €600. It doesn't.
It doesn't make any sense though, does it?
It doesn't. No, and I'm sure it costs them like pennies to make.
So how do normal people access healthcare? It's all about health insurance over there, isn't it?
Insurance. And that's why your health insurance is a very big, very important part of your salary package over there. Why people talk about their benefits, because they're, having good healthcare is essential there, because it's impossible to do it out of pocket.
Yeah. It's mad, isn't it? Yeah. When you were over there and when you were training or studying, did you, or even like as you were, I know you're working mainly with females now, did you experience any, I suppose, like misogyny or, that whole thing about, men versus women? I know in medicine now there's probably more women than there is men, certainly coming through in the colleges and that. Did you experience anything like that, or even from patients,
Patient, yes. From my, especially in Texas.
That's why I asked.
Yeah. So, myself, as a physician, I would say the opposite, Laura. I have had 3 mentors in my career. Sarah Rogers, who's obviously a woman. She used to come and visit me in Dallas. Brian Kirby and Alan Mentors. So, 2 of my biggest champions were men. And I even think sometimes, if I was a man, would Dr. Mentor have helped me as much? I was like a daughter to him, not in any sort of weird way.
Yeah.
But I actually think, it was the opposite. Men have been so good to me, and all the men in Baylor, the male physicians and whatnot. And I will tell you, Texas is a place of very strong women. The women run the show.
Okay.
You should. I don't know if you've ever met any Texan women. So no, I would say very much the opposite. I think being a woman was in my favor.
Okay.
Now, the patients, especially, not so much the Dallas men, but we had patients who came from every part of Texas. So, really rural Texas, absolutely,
They think you were the nurse, or they think you were, yeah.
Yeah, always think I was a nurse. So, and, it didn't bother me.
Okay.
Yeah. So, no, I've been really lucky, and people have horrible stories or whatnot, but I actually think I benefited in the opposite way. I've had really good men in my life supporting me.
That's great, because I know, I've spoken to some female doctors and they said, even within the hospital setting, say, nurses would even treat them differently to their male counterparts. And,
Do you know what I think a part of that sometimes, Laura, can be? It can be, because I will tell you, working in the hospital, especially as a junior doctor, I obviously did my, my internship and my, my medical SHO years and everything there. Men and women interact differently with each other, not just in the hospital, everywhere. And I think the way a woman interacts with a woman will dictate how that relationship goes on. And I think the animosity there, whatever they've experienced, sometimes can come from them themselves. There is no one better than the nurses in the hospital. Again, the nurses run the show, and especially at a good hospital, it's good nursing that does it. So if you are a nice, lovely person and ask for help and whatnot, it's never an issue. I always got on so well with the nurses. It was mainly in Vincent's, and they'll be your best ally. And again, the male-female thing doesn't really come into it there. They do anything for you.
Okay.
It could be the way, if people aren't treated with respect and valued. I think everyone has to feel valued in their job.
Yeah.
No matter where you are. And there isn't a hierarchy that doctors are in charge of nurses. Absolutely not.
It's actually nearly the other way around.
Yeah, and they're very separate roles and they do different things. And I think mutual respect, everything is going to be fine after that. And I do think some female, especially when they're younger, some female doctors come around and start bossing people around. Who's this 24-year-old coming up, ordering me around? I'm a 60-year-old nurse. There is no respect there,
Yeah.
And I think that's where some of that comes from.
Okay.
And I don't mean, of course, some people may have had, different, very different experiences to me, but I do think it's all about the way you approach people and the way you value people, and I think that's in every aspect of life.
Yeah. No, you're right. You're right. Yeah, and it's great that you've had that good experience, and I suppose maybe people that have had other experiences, there's other things going on there as well.
But they don't even recognise maybe, or even they don't recognise about themselves.
Yeah.
I've been very lucky, as I said earlier. Like I do love being a woman. I think we have so many assets, as a woman, and this trying to all be the same, taking out, I think women should be allowed to be women. And men be men, there's so much to that. I hate the thought of, men not opening doors for women anymore. You know, we
Yeah.
that, you know, so maybe I'm a little bit old-fashioned or conservative, but you know, I think for me, being a woman in this era is a great thing.
Yeah. And did you find then as well, though, the fact that you had to study, you know, so long and so hard, obviously it probably delayed you having children?
Oh yeah,
You popped two out pretty quickly there a couple of years ago.
like in my early 40s.
How did that go for you? Did you have issues conceiving or
No,
anything like that, or is it?
luckily no, and that might be down to John. He is 7 now. His brother
John's
has
like
8.
super sperm,
I
isn't he?
think they must have they
His brother has 8.
Yeah. So I think they're just a super fertile family. But yes, I had I will say a huge panic when I was 38, 39. You know that. You know, crap. You know, have I missed the boat? And I think part of that was being in Texas. I was living in a bubble over there. All my friends from school had already had all their, you know, and I, you know, I think I was still thinking I was, you know, 21, living it up, partying away, whatnot.
I've heard about you. I've heard about your party days. We'll get to that later. I did a little bit of digging.
Oh no, I know. Well, the party days, I don't think I've ever.
For anyone listening, Caitriona apparently was the type of med student that could party all week and still turn up for the exam and still ace it, whereas everyone else was studying. So you're obviously one of those like you know, X-ray memories or something like that, where you can just look at something once maybe and perform.
You know, I love tests. I always love tests. I'm one of those, you know, freaks too, and I actually. I would remember things in tests that I didn't even think I knew, you know.
Okay.
Yeah, no, I'm very, like, I really enjoy
cow. The rest just like beavering away.
Well, no,
social life.
I studied my arse off.
Okay.
And I would always come up to the exams. No, like I'd be sitting in the library all day or whatever else. But no, what was I saying there about?
The baby thing.
The baby thing, yes. I think, you know, life just goes by very quickly sometimes. And by the time I arrived back here, what age was I? Was I 36? I was 36 when I arrived back. And yes, I don't think I'd ever having kids wasn't a big thing for me when I was younger. I never said I wouldn't have kids, but it wasn't, you know, hugely on my radar. I remember moving to Dallas and Dr. Mentor's wife, Pam, who's fab, she's from Zambia. She's like, I think you should freeze your eggs. And I was like, what? And I was like, you know, I'm only 20. I don't even have a boyfriend.
Yeah.
You know, why would I freeze my eggs? And their daughter had gone through fertility treatment and whatnot. And she was like, freeze your eggs now. And I couldn't afford to. So, and it wasn't even on my, and then like when I came home and I'm 36, 37, myself and John broke up for a while. And all of a sudden I was like, oh my gosh, you know, I'm single. I haven't frozen my fucking eggs. And
they're probably too old now anyway.
Oh my God, how am I going to meet somebody now?
Yeah.
Poor Liz, my secretary, you know very well. I started getting on an internet site, you know, the internet dating things that, you know, nobody had done before I left, whatever else. I was going to get Liz to do all the screening. I was too busy. But you know, anyway, myself and John sorted things out, and we had babies or whatever else.
But I think that just goes to show you that, you know, people just do it differently, and it's whatever works. You can't, like what you said, like, you know, don't look down on me for getting help or having nannies or things like that. Like, I mean, everyone needs help. You couldn't do the work that you did without nannies, etc. Like, or au pairs. And, you know, I think the stigma of that is slowly being reduced about women getting help outside the home when they need it. But do you have that mom guilt then as well, whereby?
No, and I think, you know what I think? It's because I'm older. I'm older, and I think. I actually think now, into my 40s, I'm happier than I ever have been. I actually think as you get older, you don't sweat the small stuff. I don't really care what people think. I'm really happy in my own life. I have great friends. I have great family. And no, I don't have any mom guilt. And also probably because I've such an amazing nanny. And I have an au pair who helps out some of the time as well. And they're both brilliant with the kids. Much better than I would be if I was sitting at home all day. I'm terrible at playing with them. I'm not great at... you know, my favorite thing in the whole day is coming home to my kids and, you know,
putting them to bed.
And adore. Yes, you know, oh, that sounds. But like, I work a 4-day week now, so I have 3 days with them and 4 days in work, and you know, it works so well, and yeah, they're the best thing I ever did, but you know, I wouldn't be able to be at home with them the whole time. I think women we're also made so differently. And I have friends who are stay-at-home moms, and they're amazing stay-at-home moms. I would never be an amazing stay-at-home mom. I don't have the personality, the patience for it. I think I'm an amazing
Working mum.
Yeah. So that when I come home, I'm there, you
Yeah.
know, I'm present when I'm home. But that's what works for me. And I think this is the big thing. And you realize it, you know, later on as well. I think, you know, men don't shit on women, women shit on women.
Yeah.
And a lot of us, and actually we're very hard on ourselves. A lot of the pressure actually is internal pressure, you know, whether it comes to, if it's women who you don't really want to breastfeed, but feel like they have to, you know, I breastfed, but it's not easy for everyone. And I think a lot of that comes from nobody's even judging you. You're feeling like you would be judged. You know, that sort of thing.
Well, I think with the whole breastfeeding thing in Ireland, and I always say to people about that, you know, we haven't grown up in a society where we see women breastfeeding all the time. So I'm different. I had a midwife mum, and I had all these aunties and cousins who I saw their boobs out breastfeeding their babies from when I was a young girl. And I always grew up just thinking that was what I was going to do. So even when I got pregnant, I was actually excited about breastfeeding. That was the one thing I was really excited about doing. And it went really well for me because I really wanted to do it. Now, on the flip side of that, I did kill myself and martyr myself a bit because it was always about like, they can't have a bit of formula. You know, I have to exclusively breastfeed them. Now, there were 3 big boys. I didn't hit the 6 months at all. It was like 4.5 months I started giving them solids. But I still continued on with the breastfeeding for like 2 years for each of them. But if I had to go back in time, I would have just given them the bloody bottle because expressing, like I was using one of those awful pumps that sucked your nipples right out. It wasn't even one of the nice ones back then because that was like 14 years ago. And I remember like looking at my boobs being like literally, you know, pulled apart. Like in no way.
The Mandela ones, you know, the ones that hospital grade ones.
Yeah. Did you walk around work with them?
So in work I had LV. It's brilliant. Like they're expensive, but I had a double LV pump, and you just stick them in your bra, and I used to see patients with them on, because I'd collect the milk and keep putting it in the fridge.
And would you notice?
No. Like my boobs looked huge, but it was these things stuck onto them. But I always sort of more flowy dresses so I could get them in and out quick.
Yeah.
And no, the patients didn't even notice they were on, apart from once. I was doing someone's filler before, and she was like, "Oh, Caitriona, what's the noise? Is this the chair?" And I said, "No, it's my breast pump." And like, well, she didn't
say she roared laughing, did she? Oh no,
it was funny at all. I thought it was funny, but like she didn't. So I stopped doing it. I stopped having them in when I was doing fillers or anything close up to a patient.
Okay.
Then. But yeah, so that worked great for me as well.
Yeah.
So I could, you know.
But like that, what I was saying is that, so I grew up around that. It was the only thing I was ever going to do. And I remember going to a friend's house when one of the babies was small, or no, I think it was my eldest. And I was feeding him, and their like 8-year-old was like shocked, like, "Mum, like what's she doing? Like what she do?" You know, because she'd never seen it. She'd never seen, because my friend had bottle fed, and all her sisters had bottle fed, and all the rest. So what we do in Ireland is we put this onus on women. We're like, "Oh, you should be breastfeeding for 2 years. The WHO say it's brilliant," and then we send them packing with very little support, I think, from what women are saying to me, you know, coming out of hospital even now. And then they've never seen anyone breastfeed in their lives, or very much off it, apart from being told to do it. And they're not, you know, especially when there's these Gina Ford books going around where you're supposed to have your babies in this sleep schedule and pick them up, top them up and put them back down again. And that doesn't work out really with breastfeeding. So I think that, like you said, women are very hard on themselves, and we, you know, put the pressure. And like, there's no husband is ever going to turn around, or if they are, they're in an awful minority, and insist on a woman breastfeeding their child. They just want their wife to be happy and get on with things. And, you know,
and I think there's this huge thing, you know, because I think being a mom is probably the most important role in anyone's life, whether they're a working mom or they're not. But they need to be the super mom. You know, they need to do everything right, and I think that's why people are afraid to share when things aren't going well. As well. Certainly, I found, you know, my friends, a lot of my friends came to me and told me that they had postnatal depression, but they hadn't told the rest of, you know, people don't share their experiences or whatnot. People will always come to me because I'm the doctor. But it's a tough time. But I think, as you say, it's coming from the inside out. I certainly think that. I was just talking to someone a couple of weeks ago, or it was last week at the horse show. And she was really struggling with breastfeeding and felt terrible anytime she gave, you know, formula or whatnot. But like, when things get to that stage, I think it actually is anti-bonding. You know, but one of the best things about breastfeeding is meant to be the bonding. And getting to that point where you hate doing it every day, then it's not the right thing for you.
No.
You know?
No.
But yeah.
But like that, it's like women putting pressure on themselves. It's like some of those confession boxes that I put up on my Instagram. Like women are messaging me going, oh, you know, I think my vagina is really big. I'm wondering if my husband is enjoying himself. He says he is, but I'm wondering if he's enjoying himself. And I'm like, well, if he's saying it is, like if he's not complaining, like complaining is the wrong word because he shouldn't be bloody complaining in the first place. But women are putting themselves under this pressure to have to snap back. Like if you're going to push a 10-pounder out, you know, it's probably not going to be the same. But if no one's complaining, why are you looking
Listen,
for?
as long as they're getting the action, I don't think they care how tight it is. Sorry, and that's a little bit whatever, but
I don't think so.
No. Sure, a lot of men don't get it for at least a year afterwards. Like, you know, it's so funny when you talk to people. Everyone's so different. That was one of the funniest things I saw you put up. And I actually think everybody was so interested in the answers. How often do you have sex?
I know.
You know, people don't talk about these things.
No, they don't.
You know, and then
and what's normal? What's the normal amount of time to have sex? Like, I mean, it's whatever works for you, and so long as people are happy-ish. Like, you know, I don't think you can. I don't think, you know, are men ever going to get as much as they really want? Probably not.
It's true. But it is. It's funny that way.
But you have that Emsella chair in your place. Is that popular?
It is. Oh, it's definitely popular. You know, more for incontinence than anything else. But actually, you know, one of the aspects of it, what it's doing is it's super contracting your muscles. So not just your pelvic floor muscles, also your vaginal muscles as well. So it is. It's meant to improve sexual function. And certainly when again, probably too much detail, but I said, you know, there's a lovely girl who runs it all runs BTL is the group. And I said, listen, you know, because it's 6 treatments that you need, I'm not buying it unless I see a difference myself. You know, there's no way we're having patients spend money on treatments or whatever else unless we know that they're, you know, it's going to deliver for them. So I had my 6 treatments, and I said, John, I was delighted because I was like, do you see any difference?
We have to go again just to see if we have to try it again just to see if there really is a difference.
It definitely made a difference for me. Actually,
okay.
Let's get back on it, because it's not like you know,
doesn't do it forever.
No, it's like going to the gym.
Yeah,
you know, it's same with the Emsculpt for your tummy. Like, you know, and I try and tell people this: it is a temporary fix. You have to keep it up. You know, as in either you're doing the exercise or you get back on the machine. But John said, if you don't buy that machine, I will. Not that he can afford it, but so that was it. Sold. He was delighted. Yeah, so we got an Emsella. So it's not just incontinence. It actually, as you say, tightens, you know, as well. And having stronger muscles there increases arousal, but certainly improves orgasm.
Yeah.
Which, you know, is elusive for so many women. Again, I don't think you've ever talked about that in your confession box, but like the amount of women who do not orgasm.
I know, but the
phenomenal.
amount of women that have never orgasmed, or they say, I don't know if I've orgasmed. And I'm kind of like, well, you probably would know if you've orgasmed. So yeah, no, it is. But like, and that's the whole thing. It's about women and their bodies and trying to, I suppose, make.
But isn't it funny that, you know, the question is, you know, my vagina is obviously bigger now. You know, I wonder, does he still enjoy it? Why is it about him? You know, you know, are you still enjoying it? It is funny. Again, women, it's how we're going to be perceived by everyone else. It's not about
how we feel about ourselves.
Am I enjoying it as much? You know,
I know.
Yeah, you know, and we are like that. A man is
like
never
you
going to
say, it's like the pressure you're putting on yourself.
Yeah. Are you going to be good enough for your husband now? You know,
is my penis big enough for you?
That will never be asked.
That will never be asked.
Yeah. Ever. But it's true.
Yeah.
You know, men don't feel the same, you know, onus on them to please, you know.
Well, yeah, I suppose. We are talking about vaginas. As you know, I do love talking about vaginas. And I wanted to bring up lichen sclerosus with you, just moving swiftly onwards. Caitriona, get it?
Okay.
So we can get it back onto the dermatology topic. So I'm asked about it all the time. I know enough about it to know that I'm not good enough to give advice on it. So can you just briefly talk about it? Because it does seem to come up an awful lot.
I'm so surprised that you're getting asked about lichen sclerosus. So lichen sclerosus, it's a very unusual condition in that we don't know why it happens. It typically happens post-menopause or perimenopause, where the tissues, it's an inflammatory condition. So the tissues get inflamed and then they shrivel down and scar. So what happens
in the vagina, by the way, just
well, not the vagina actually, as much as the vulva, the outside. So the labia, then the whole introitus. So the introitus is the entrance. The vagina tightens around the anus, tightens. It's like, and you see white tissue that sort of surrounds all those areas. It can be incredibly itchy, but worse still, it can be painful. Like the skin can crack, but it can be very painful to have sex, penetration, and sometimes when I speak to women, their whole of their vulval lips are gone completely. Their clitoris is absorbed. They have no clitoris left.
Oh my goodness!
And the orifice,
and that's from the scarring and continuously over.
Because they don't even realize it for a long time. It's a very sort of it's an indolent thing that just progresses and progresses, and it can be so advanced that they cannot have sex. And that at that point, I send them for gynae physio. For it's usually applicators that are needed to gradually open the orifice, but even when that happens, it can be so painful to have sex. So it's a very debilitating thing. There is another variant of it that happens in young girls, children, who are sort of 5 and 6.
Okay,
and that's devastating.
Well, it can't be common though, is it?
It's not huge. I don't know a percentage. Laura, I wish I knew, but no, it's not common. It's certainly less than 1% of the population. The other thing we have to be careful for, though, especially in the untreated, some women go on to get a skin cancer within that scar tissue. So I see all these women, once we have them sort of controlled, and it's usually just topical steroids that we use. And is
that the only thing that can be used? There's no injectable.
If you get it on top of it early, you stop that inflammation that allows the scarring. And then I use vaginal estrogen as well, so Vagifem, Vagifem is the brand that I prescribe. I should just say topical estrogen to help strengthen the supporting tissues, because that can help as well. But it's a really tough one.
So it's not an autoimmune disease?
It's auto-inflammatory, yeah. But and sometimes people can have little patches on their skin, but they're usually, they don't interfere with the person as much.
So it's kind of not treatable as such.
What we were trying to do is stop it in its tracks so it doesn't progress, so that the scarring and the destruction of tissue doesn't continue. And there's a couple of experts in it in Dublin, dermatology wise. Catherine Foley in the Beacon and Aoife Lally in St. Vincent's are excellent at treating it.
Okay. And can GPs treat it though?
Yeah, they can. I think the most important thing is identifying it. Okay. Because it's the one condition that we use potent topical steroids, so the likes of Dermavate, in that area, because calming down the inflammation is much more important than any little bit of skin thinning that could happen, because actually skin thinning will happen to a much bigger extent if you don't use it.
Okay.
The atrophy.
But could people be out there experiencing recurring thrush because the whole vaginal area, I just think with women in general, and that's why I go on about it so much, is because we're not taught to talk about it from a young age, because you're not allowed to talk about your vagina or your vulva. As a young girl, you're not supposed to. We go through life kind of like putting up with issues down there. So I would have seen a lot of women coming into the pharmacy on a regular basis for, say, chronic UTI infections, or acute UTIs over a period of a year, but they're getting like multiple antibiotic prescriptions for them, and then they're looking for Canesten cream all the time because they think they have thrush. But in actual fact, it's just the natural genital urinary syndrome with menopause, whereby if they just had a bit of estrogen cream or a bit of some vaginal estrogen as well, it really helps them and they benefit from them. And I would have sent, many of them back just to the doctor just to say, listen, just get your doctor to prescribe you this, and they come back and literally within a week or two, they're feeling a massive difference. So
huge, especially topical estrogen.
It's just unbelievable. So are there women maybe out there treating themselves for years thinking they've thrush and it's actually lichen sclerosus?
Yeah, absolutely. Or they just think they have an itch, but they don't. It's quite, unless you've seen it. Because it doesn't look red, it gets more pale and more pale. It doesn't look to the patients and sometimes to their GPs like anything at all, and they don't realise half their labia are gone. It's really, really sad, and I think actually doctors in general aren't very good at vulvas.
No.
Anything that looks a little bit red and itchy, they throw
A bit of
of
thrush at
Canesten
it, I know.
and a bit of cortisone cream. Certainly some women can be plagued by recurrent thrush.
Yeah, no, I know. It's just one of those things. Like I hope, like we are progressing. There is a lot more talk about it, but I just hope that there will be more. In terms of waiting lists to see dermatologists, I'm always getting complaints.
Yeah.
There's very few of you in Ireland.
Yes.
And then to get on a waiting list can be, it's increasingly longer and longer.
Yeah.
Is there anything that is actively being done about that? Is it just about we need to recruit more dermatologists? Why is there so few? Is it just that it's a very long training scheme? Do you have any insights into that?
Loads of trainees. It's just the positions being made in the public system, and that's what needs to be done. And there are lots of trainees out there ready to come back to take posts. So it's more about increasing capacity, especially in the public system. Like some of the public waits are crazy, and as a result, people go privately. But the private waits are crazy too. My next new appointment is 2024.
Yeah, it's crazy, isn't it?
Yeah. And I think, most dermatologists have, private dermatologists have quite a wait as well. But there was a point that only one new person was being trained per year,
But that's all.
And the reason being was because there were no posts to give them, because new consultant posts hadn't been made, in the main hospitals. So you can't train a whole load of people and then they're sitting in limbo with no job at the end of it all. So that's where the problem came from.
And is it also a case of Ireland just isn't attractive for people to come back to either in terms of going into the public sector and working because the money isn't there or the lifestyle isn't there that say someone in Australia could have? Like doctors in Australia would often talk about like coming back to Ireland, they're just giving up the work-life balance they have over there. Is that something that is an issue?
No, not really. Like there's nobody over in over in Australia or the States, or there's one other dermatologist in the States right now who's Irish, that I know of. There's a good few in the UK, and they'll go to consultant posts in the UK. I think getting this next contract right is so important because it's not just we have a brain drain, and it's so important that we have good doctors in the public system as well as the private system, because my fear is that more and more patients. I moved to the private system. It was more to do with the infrastructure of things. I can be a much better dermatologist, in the private, based on the job I went back to. But people have to be
As in you can see patients more regularly, you can look after.
Yeah. I still hadn't got my own clinic after a year of being back, and it's just to do with the logistics of things and whatnot. St. Vincent's is a brilliant hospital to work in, but we need our public system to be run by excellent doctors.
Yeah.
And we have those excellent doctors, and they need to be reimbursed as such. And I think a big part of that is that they're allowed to do their private work on their own time. A lot of them are, the sole provider for their families, and they see their peers in all of these other countries making, a lot more money than them. And it does come down to things like money.
Yeah.
And again, I think that's part of being valued, for the most part, between, I was training from the age of 18 until 34. It's a huge amount of training that goes in. So I do think people have to be reimbursed well and be allowed to do the private practice that they want to do as well, because that's what's going to keep people in the public jobs. If you tell people that they can't, work harder outside and, and provide for their families, you're going to lose them. It's as simple as that. And we've such bright doctors, who are, especially in other specialties, who are sitting all over the world.
Oh, I know. Sure, I have some of my family that are all over the world.
Yeah.
Yeah.
Especially in certain specialties that are all just locked away over in the States and would love to come home, but they cannot leave the salaries that they have, and the great infrastructure they have in the hospital. To come back to these crappy jobs and not even have a secretary and not have whatever else, that has to change, and our health system will implode if it doesn't change soon.
Absolutely. And like you said, not have the secretary or not have the infrastructure around them. And it's about the fact that, the hospitals and the fact that the waiting lists are huge, and the lack of even nursing staff available, etc. So it's the brain drain from everywhere and every aspect of the hospital system, which is
absolutely, like in the States, you finished and people were vying for you to come to, to work for them, and giving, offering you, great salaries and whatever else and all the benefits that would come with it. And then, you're coming home to interview, to beg for this job, and like 10 other great candidates beside you. It's so wrong. You don't feeling sought after or valued is totally gone out of it. Then
Yeah, of course. No, that makes sense.
Especially when you've worked your arse off, to be the best doctor you can be and get the best training you can have, and that's so many doctors all over the world.
Yeah,
and some of them sitting in other countries with their families. They've taken their whole family off to do the amazing fellowship training they've done and done whatever else. And then they can't get a decent job back home. It's sad.
Yeah. I'm going to wrap this up with a few quick fire questions that I got in. Okay.
Yeah.
So, is the expensive creams are the expensive creams like Environ, the Image, all those, are they worth the money, or can someone have a really good skincare routine on a budget?
Yes, absolutely. I try to say this to people the whole time. You've no idea, Laura, how many people come in and pour thousands worth of creams onto the desk. And, half the time they're making their skin worse. There are only two things I care about: a zinc sunblock and a retinol. That's all they need. Like, that is all they need. And you can keep it really, really simple. Gentle cleansers from the pharmacy are perfect. My favourites are the CeraVe Hydrating Cleanser or Cetaphil Gentle Cleanser. They're full of ceramides or whatnot. Just a zinc sunblock in the morning and a retinoid at night time. That's how you future-proof your skin. Keep your tone and texture looking as good as it can look.
Teenage acne, like where to start with the zits and things like that, just in terms of basic skincare that they'll use?
I think the simplest thing is washing their face morning and evening.
Yeah.
I know that sounds what I often tell my patients to use that are very mild acne or more sort of blackhead take acne is just Effaclar, the wash morning and evening.
Okay.
And after that, if there's more inflammatory activity, just getting them to the GP ASAP, especially if there is any signs of scarring.
Okay. Skin tags. Can you remove them yourself with a thread?
Yeah.
Okay. And you'd be all on for that?
Well, it's easier to just get them frozen off by your GP or your dermatologist. But I remember doing that to one when I was much younger.
Yeah, you just wrap the thread around it and it kind of falls off then, doesn't it? You're cutting the blood supply off. Okay.
All we're doing anyway when we're freezing them is destroying them. So destroy them anyway. Like, don't take a knife to yourself or anything. But that's no issue. Okay.
Pregnancy skincare. What should they use, especially if they've been like mad into the retinols and that, and they've to cut all back?
So you can use everything apart from retinol.
Okay.
So sunblock is really important. I know I talk about sunblock the whole time, but you're much
really
more
boring actually the way you go on about sunblock.
I know, but it is the one thing. It makes such even a year of you using it every single day makes a difference. But definitely, because so many women pick up a little bit of melasma that they can't shift forever. So sunblock even in the winter is the most important thing. But everything else you can use, like the vitamin C to brighten your skin because you won't have the retinol, and lots and lots of hyaluronic acid.
Did you use Botox when you were pregnant?
Did I do it myself?
Yeah.
Yeah, but I would never do. God, Laura. I'd probably put in front of the medical council or something now. So yes, but I would never, ever inject a patient, just in case anyone who's pregnant is thinking of booking you with me. No.
Okay.
And that is because things go wrong during pregnancy and I will always be blamed.
Yes.
But there's lots of retrospective data, and Botox doesn't... the molecule will be too
not
big to get over.
Absorbed into the
yes,
bloodstream
yes,
anyway.
yeah. It's not absorbed into the bloodstream. But I suppose the other thing is so many women get Botox when they're pregnant by accident. They don't realise they're pregnant yet, and it's no issue.
Botox and breastfeeding?
Breastfeeding, I'm good with. Now, allergen, I keep asking them because I just want to have it from the horse's mouth, and they say they have no data, so they do not advise Botox
they're just relinquishing themselves of their responsibilities there too.
But a brilliant resource, and actually this is searchable for the public as well as LACMed.
Oh, it's brilliant.
It's really, really good. It's really, really sensible, and basically it says it's fine. So it shouldn't be absorbed. Even if it is absorbed, it will be negligible. It won't pass over to the breast milk. It's not in breast milk, so I'm fine with that. And people don't need to pump and dump Like
No, but people actually don't need to pump and dump really ever, even when they're drinking alcohol.
Yeah.
And I say that to women. I talk about boxing women off that breastfeed into another little box of you can't do this stuff, which makes it even harder for women to breastfeed.
Oh, listen, I had
you can
little
totally
strips,
have a little drink.
I had little breast milk strips that I could dip. I could dip my my breast milk and see if there was any alcohol in it, and there was never showed anything.
So what were those strips?
You can
The little pH strips?
No, they were alcohol in your breast milk strips. Google
I never even knew that existed.
So
but
that just makes you feel, you know.
I'm not surprised that you invested in them, Caitriona. That doesn't surprise me.
So I had them and I never detected anything.
Yeah.
And my sister's a paediatrician, and Emer will be, you know, no alcohol during pregnancy, ever. You know, everything you put into your blood is the baby's blood. That's it. And Emer drank like a fish always when she was breastfeeding. And I wholly trust her, but I did the strips anyway. So she would have no issues with them because of it's a negligible amount, and the rid is so, you know, will be the rid on the actual whatever. Don't have to worry the baby breastfeeding. Absolutely have to worry about the baby pregnant.
Absolutely, yeah. And just if anyone is breastfeeding and having a couple of drinks, just don't sleep in the same bed as the baby as well. That's just important to note too. It's the important one. Best treatment for eczema. Now I know there's mild, moderate, severe, but just if you're, you know, if you've just your regular eczema patient that's coming into you, not the really severe one, someone that's suffering topical steroids
and loads and
moisturizer.
And always try and get a moisturizer that has ceramides in it, because what you're trying to do is restore the skin barrier. So what you're hoping to do usually with your eczema is not have it in the first place, and that's keeping your barrier really well, you know, protected, and that's with the moisturizers. So, you know, if you can do more moisturizing, you're going to do much less steroids, and that's just the way it is. And winter, you just have to up it between the central heating and the dry coldness that we have.
Yeah,
it just gets so much worse in wintertime.
Yeah. And then kids that are allergic, you know, when they go into the pool and their skin gets all kind of itchy and sore, is Vaseline good enough to put on as a barrier cream just before they pop into the pool, or no?
Yeah, but how are you going to put Vaseline on their whole body?
Yeah, well, if it's just like a little patch or that.
Oh, a little patch, fine.
Yeah.
And the biggest thing though is not to bring the kids home to have their bath or shower. Shower them there. Get the chlorine off, because they won't be allergic to the chlorine or whatnot. And my favourite soap substitute is just aqueous cream. So if you can use aqueous cream as their soap in the shower, in the swimming pool, that's the most important thing.
But not as a moisturiser, isn't that right?
No, it can be irritant.
Yeah.
An irritant.
But it's okay as a soap because you're washing it off,
Right,
but definitely not as a moisturiser.
Not as a moisturiser, no.
Okay.
Yeah.
I'm trying to think of the other ones. Oh yes, hyperpigmentation. What is the best?
Hyperpigmentation.
Yeah.
So, well, it depends. If it's melasma, the thing that's going to get rid of it is hydroquinone. So, and that's prescription based. But there's no point in doing anything if you're not doing your zinc sunblock. Like, that is the key. So many people have gone for so many treatments, they're not using they're just using a chemical oil sunblock. So, and if it can be a tinted sunblock, even better, because the tint blocks out visible light. The iron oxide in the tint blocks visible light. So from computer screens, from like strong lights and whatnot too. So that's really important as well. Some people, especially darker skin types, visible light can cause a lot of their pigmentation. So they're indoors with the curtains closed and they're still getting damage.
Okay, that's important. Then everyone knows.
And then the other. So there's three components to the melasma treatment. The sunblock is the key. Hydroquinone to get rid of it, and also some form of retinoid. You know, either tretinoin, either prescription, or retinol to normalise the way your skin pigment's going forward.
Okay. Hair loss is a huge issue that affects like loads of people, especially as they're aging.
Yeah.
What, if anything, can be done?
Well, it depends on what type, but if it's female pattern hair loss, which is what you're talking about, which is very similar to male pattern, just much more slower and more insidious, and actually much more diffuse. You know, men's usually get with men, their hairline goes back. With women, it's that you're seeing lots more scalp everywhere. They're losing it all over. The best two things that they can do over the counter are Regain 5% foam. You know, the foam is more potent, even though everything's 5%. It's a better vehicle. 5%, and keep going forever. You'll have more. You'll always keep as much hair as you can keep.
Yeah, you can't stop using it. That's the problem. I think people think that they can do it and then stop. You need to keep it up.
Keep it up.
Are they bringing in the tablets soon? Are there?
Yeah, I use the tablets.
Yeah.
So that's prescription. But I use usually finasteride before that, finasteride or spironolactone. And then I add in the oral minoxidil, especially for people who can't tolerate the retinol.
It isn't. It isn't. I mean, I don't see loads and loads of prescriptions for them though.
No, it was more of a recent thing. So it's over the last 10 years, it's crept in. I'd say I probably have about 40 or 50 patients on it. The other thing is making sure that their vitamin D, their iron stores and are replenished. Remember, I talked to you about. I think your FabU, the complex that has
the shrooms one,
D and zinc
and copper,
and copper in it. That is to make sure that your nutrients are always as good as they could be. For hair growth, and that's really important more for telogen and effluvium. And then Viviscal in clinical trials has shown for female pattern loss and pattern hair loss and male pattern hair loss to be of benefit. You go to, if it's getting worse, you go to your GP or to a dermatologist. And for women, spironolactone I usually use in women who are pre menopause, and then finasteride for women who are after. And sometimes I add in oral minoxidil.
Okay, and then just to reassure women that are pregnant and they've got all that massive hair when they're pregnant, and then they have their baby and they think that they've lost all their hair or they're losing it.
All comes back.
Yes.
Yeah. And that it happens to pretty much everyone. You should have seen my sheds after my babies. I'm sort of prone to telogen effluvium, especially when my vitamin D goes down. But it all comes back. And it's always like nerve-wracking for people when they start to see their hair coming out in clumps. The issue is you're going to have to wait. The hair cycle is 9 months, and then it has to grow, so it will come back.
And to get as much good nutrition, to get as much sleep, especially as a new mum. And I know people laugh from when I say that, but that's actually the best thing that they can do for themselves is to get as much sleep and rest and as much help. And if you can afford help, do it. Get it. You need it.
Sleep ask for everything.
I know.
Like sleep. Without sleep, you're a fraction of your usual self.
Yeah. I didn't sleep well last night, but I think today's podcast went well.
Really well.
I have 2 questions that I ask every guest. So the first one is, what advice would you give young people today? And the second one is, what is the meaning of life?
Okay, well, very profound. Well, the answer to the first one is obviously wear sunscreen. When you're 40, like
you couldn't be a derm and not.
No,
say that.
What advice would I give? What it would be, I think. To younger people, it is like keep an open mind to everything. Remember I was talking earlier about how I didn't mean to stay in Dallas, but curveballs will be thrown at you. But actually, all of the biggest disappointments in my life have been the turning points that the best things came out of. So it's your attitude dictates so much, the way you deal with things, and have that open mind. Let anything happen. Travel. Like travel, because you can never travel the same way once you have kids. Live in, scum buckety places and whatever else. Like travel as much as you can. I think, so important. And just believe in yourself. I actually feel like I'm only truly happy now in my 40s, but there's so much self-doubt, and just believe in yourself, I think is so, so important. And then what was the other one?
What is the meaning of life?
The meaning of life. Okay.
You did a lovely little cross-eye there. I hope we caught it.
Right.
It was lovely.
Well, I think, Laura, life is for living. And it's just getting whatever happiness is for you, and it's different for every single person. But I think getting the happiness out of every day. Like so many of us are working towards different things, and we think that's going to make us happy. But the happiness in your day, like, happiness from your job, I have so many patients coming through the day and that make me happy, and then I go home and I have my kids. It's those things you have to get the happiness out of.
Yeah.
Live in the moment, not these aspirational goals that you have. I have a friend who's very sick at the moment, and things, I often think of him whenever I start getting stressed about someone, or something, the little things that we all stress about. He would feel so lucky for them to be his problems now.
Yeah.
So I think it's being grateful and valuing what you have right now today, and getting as much happiness you can out of today. It's so much about attitude. I remember there was a taxi driver I met before, and he just loved it. I remember he was chatting, and he talked about how much he loved his job. So many people focus on everything that they don't have rather than what they do have. And, right now I feel like I'm so lucky in so many aspects of my life, and it's about living it,
Absolutely, that's lovely. Thank you so much.
Thanks.
Professor Caitriona
Thanks,
Ryan.
Laura. Thank you.
It's been an absolute pleasure. I'm sure loads of people learned loads from that.
I hope so.
Okay.
Thank you. Yeah.